Good morning, good afternoon, good evening, wherever you are. Thanks a lot for the opportunity to present in the second Artificial Intelligence in Infectious Disease Workshop 2025. Our accepted abstract is titled Development and Evaluation of a Question and Answer Dataset for Sexually Transmitted Infection, and I'm Henry Semakula, and I'm going to present on behalf of the authors. We come from HASH. HASH is an innovative hub on artificial intelligence for maternal, sexual, and reproductive health in sub-Saharan Africa. And this is our team, HASH. Straight away, we did a crowdsourcing of a STI dataset where we asked questions to participants between 15 years and above. The crowdsourcing was done via an online platform called Slido, and a paper-based submission, and also in-person interaction at public events across sub-Saharan Africa. The medical doctors anonymized the dataset and provided accurate and evidence-based answers. The answers were in two formats: a short and a long answer, or what we call a simple and a detailed answer. The size of the dataset is 5,488 question-answer pairs. And how did we do it? Like the way you said, the conferences that we attended, and also via social media, where we shared this poster, and the person was just supposed to scan and log in, ask a question, then the doctor in the background could respond. From there, we picked a sub-study, and the objective of that study was to compare human-generated answers from the Q&A dataset that we crowdsourced versus a selected LLMs. The aim was to evaluate how each one performs across defined metrics and to have a better understanding of the potential and boundary of LLMs in delivering accurate and sensitive sexual and reproductive health information. These are the methods that we went through. One, we had to select LLMs. We had both general purpose and medical LLM. We selected GTP 4.1 mini, which is a general purpose LLM. We selected DeepSeek R1, a general purpose LLM, and MediLama 2, which is a medical LLM. From there, since the dataset had two responses to a question, or two answers to a question, we had to think of how are we going to prompt to generate those answers when we are prompting the LLMs. For generating short answers, we used low prompting. For generating detailed responses, or what we call long responses, we used zero shot prompting. So we had to select a question. We didn't use the entire data set, so we used systematic randomization technique, and we picked out 96 Q&A pairs from the data set. That is the data set generated, the responses generated by humans. So from there, after the prompting, the LLMs, we compiled the answers, and we had to encode the responses so that when we give it to the humans as a judge or to the evaluators, they don't know that this answer is coming from LLM, this answer is human. So we encoded the responses. So for the evaluation, we had 9 domain experts, doctors, nurses, and public health experts to do a blind assessment of the responses against the metrics. This is the tool that we shared to the evaluators, and they had to score the responses. For evaluation, we had factual accuracy, relevancy, comprehensiveness, and empathy. They were scoring it from 0 to 10. And for binary, where they are saying yes or no, we had ethics and safety, red flag, and also we had a minimum level of education. They had to tell us which minimum level of education can understand this response. And these are the results from the simple responses. The humans outperformed the LLMs across factual accuracy, relevancy, and comprehensiveness. but the humans were outperformed by Medilama 2 on empathy when it came to simple responses. For the detailed responses, GTP 4.1 mini outperformed the human in generating detailed responses, as you can see. So what we had to do is to get the average in terms of generating simple and detailed responses. How did LLM perform against the humans? The humans outperformed on average on factual accuracy, relevancy, and comprehensiveness, but they are outperformed on empathy by Medilama 2. For red flag, responses generated by humans had a minimum of red flag. Red flag, we are looking at whether the response has some bias, misinformation, and inappropriate framing. Most of the answers generated, around 40%, answers generated by DeepSeek had the element of red flag. Similarly to detailed responses, still red flag, answers generated by DeepSeek had the element of red flag, and the humans were performing very well on that aspect. For level of education, you find responses generated by DeepSeek could be only understood by, most of them could be understood by medical professionals, and that was the highest level of education. Responses generated by humans were able to be understood by people of all level education in Uganda. Similarly, for the detailed responses as well, still DeepSeek, their answers were only most of the answers were understood by medical personnel. And the humans, most of their answers by O level as well. So to draw a conclusion, we used Cohen's kappa, which is a statistical measure that measures interrate agreement between responses. So we are looking at responses of human versus each LLM. 0 indicates no agreement, and 1 indicates perfect agreement. In other words, the answers between the two are in perfect agreement. So we used unweighted kappa, and we found out that Medilama 2 produced answers that are almost similar to that of a human being, or to the health to the health professionals, in other words. Similarly, we used unweighted weighted kappa, but still the results were the same. Weighted kappa looks at the difference between the two responses, but still Medilama 2 produced answers that were fairly similar to that of a human being as well. So to draw conclusion, human versus the LLM, the health human expert excelled in accurate and providing contextually ground responses. LLMs outperformed humans in producing on empathy and producing detailed responses, but they had more red flag. So answers generated by LLM had more red flag compared with that of the humans, and that is a safety concern. So therefore, we draw a conclusion that LLMs cannot replace humans, but rather they can complement humans in delivering sensitive sexual and reproductive health information. So integrating human expertise in AI will bridge access to reliable sexual health information, and our future works are to expand the evaluation into a framework and also to improve the data set, and also we co-design AI tools with the local communities to strengthen trust and usability in an African setting. Our limitation of this work was the question and answer pairs were generated in English, yet we have over 100 languages in Africa, and also the crowdsourcing that we did require digital literacy. And also the other thing is LLMs are improving at a faster speed. I would like to acknowledge the study team, our funders, and study participants. Thank you for the work that you did. And please, you can reach out us. You can reach Dr. Rose at the mail, and also you can reach me, the data scientist, at that mail. Thank you so much. For any questions, reach out to us. Thank you.